of speaking to you, I'd like to talk about the topic of bridging the gap between injury prevention research and safety promotion practice. And thank you for coming along, because I think this is an important issue. I should just state my background. My actual paying job was a clinician. I'm an emergency physician, and a medical educator would be where I earn my salary. And now injury prevention is a bit of a hobby. But I guess the thinking of emergency physician is probably reflected in emergency physicians are very practical people. And I guess we know that sometimes we actually have to start treating the patients before we know the diagnosis. So we know that in our emergency department, patients die from physiological failure, not from diagnostic failure. And so I don't have time to get the right diagnosis. I have to get on and start treating the patient. And I think that metaphor applies to, I think it's way past time. We've got more than enough information to know that patients are dying around us, and it's time to start doing something rather than just endlessly doing research. Now, in the emergency department, we get to see it all, and we certainly, our weekends are dominated by sporting injuries and alcohol, and dare I say that the two might be related, and there's a challenge for some of you researchers out there. I do start to wonder if the link between alcohol and sport in clubs may be actually undermining any health benefit that you can get from being involved in sport. So certainly our weekends are dominated by sport injury and alcohol type problems. I like to call injury the occult epidemic, the epidemic you're having when you're not having an epidemic. I came to Mackay from Adelaide and was horrified by the amount of severity of injury that I saw. And nobody working around me seemed to think it was a problem, didn't seem to think it was particularly unusual. But here is the two front pages from the Daily Mercury, our wonderful local rag, and as you can see, basically all of them is about injury, and I don't think there would be a day in our paper where the first one or two pages doesn't have an item about someone being injured. So this is a very important public health issue. As an emergency physician, I took the view that there had to be something better than the Humpty Dumpty approach to this problem. So that's how I got involved in safety promotion and injury prevention. To address this topic though, I actually think it is very helpful to go right back to the beginning of public health and the Broad Street pump story that maybe so many of you are familiar with. But can I suggest that you might not be quite as familiar with this story as you ought to be. Now this was a big issue. Cholera had travelled from India and it had literally gone across Europe and decimated the population of Europe. Months before it struck England, there were riots in the streets in St. Petersburg because people were taking their relatives to the hospital and they were dying. So, doctors and nurses were being lynched, and, this was a big issue. And everybody knew it was coming to England. It was just a matter of time of when it struck. So we tend to think that this is all very academic, but everybody was worried about it. Everybody knew it was coming. It's a bit like the media picked up the flu epidemic. There was a lot of talk about this in the media. That's interesting. So it was more like this than academic. So, Soho turned into a ghost town. More than 3/4 of Soho residents packed up and left town last week in response to the recent cholera epidemic. Fears that air pollution, or miasma it was called, had risen to lethal levels drove the residents to the country in search of fresh air. Now, just to get an idea of what London was like, it was literally a sewer. There were animals roving through the streets on their way to the abattoirs. There were literally animals housed in housing, in tenant. So London stank at this time, so you couldn't see bacteria, but it was certainly very obvious to everybody that there was a big stink going on. Now, of course, the Puritans thought, well, just desserts for places like Soho, and so that theory was most definitely around that, this is not our problem of the nice people, but really this is God's judgment on the poor people and their wayward ways. And of course, you know, it's not hard to imagine a comedian laying in there and someone like Billy Connolly saying, you know, what's new, London, Soho always gave me the shits, and you can imagine how everyone would be upset about that, and you know, his next performance would be cut down. So can I just say, this is what it was like. It wasn't academic papers, this was in the media, people were concerned about it. And so much so that the gentlemen were out wandering around London taking measurements, which the poor people thought was really quite interesting, because the gentlemen had never taken much interest in them before this. Chadwick, a famous social reformer, who really articulated very well in the time the idea that poverty was associated with disease and illness, and he actually did some studies to show that, and he really argued very strongly in his poor laws and things like that, that, you know, something could be done. Now, from our perspective, that doesn't seem such a novel idea. But at the time, people were very, you know, it was really, you know, basically shit happens, people die, it's God's judgment, there is nothing that we can do about this. And one of the major changes in this time of the scientific revolution is that people actually thought that maybe they could do something about it. And people like Chadwick drove the idea that maybe there was a political solution. The only problem was, he was a self-opinionated snot really, and he really got everybody irritated and generated more than a little resistance. Now, he thought this problem was caused by miasma, the stinky streets. So the solution to that, since all the sewer was in the streets, building up in cesspools, was to actually have a sewage system and take that away, that stink, if you like, away from the streets, and that would solve the problem. Now, of course, in retrospect, we know that that made it a whole lot worse, because in the period of, it started sort of in the 1940s, and over a period of 6 years, they were really just basically putting a huge amount of sewer straight into the Thames River. It was even made worse by the fact that the wonderful water closet had just been invented. They had had the Crystal Palace, the international demonstration, and everyone was struck by how wonderful the water closets were, so they wanted one in their house. And of course that substantially increased the amount of sewer. So, you know, this was the perfect storm arising. And that was the environment in which John Snow did his research work. Now, in the first, and he believed that actually, he believed that it was contaminated water that was the source of the cholera epidemic, which of course everybody else in the world knew that was total nonsense. And besides, it was pretty disgusting to think about, you know, getting sick by drinking your own you-know-what, so they didn't like to think about it. So he was definitely out on the limb with this idea. But he saw a research opportunity, a natural experiment, that basically there had been a change, and the Lambeth Water Company had changed its intake from the water to 20 kilometres upstream. And most importantly, there was an area of London where there was dual water supply. So that this was a great experiment. If you like, if the problem was miasma, then everybody would be affected equally. If, however, the problem was the contaminated water, then he would be able to tell the difference, because here was a part of London where some people were drinking water from one water company and the other were drinking water from a water source that was 20 kilometres upstream. So it was a fantastic natural experiment. And here are his results, which really show that there's a dramatic association of cholera with the Southwark Water Company. So he had that idea, and then suddenly disaster struck. And you can see that huge spike, which is the Soho epidemic. And in one night, I think on the 31st of August, some 126 people died quite suddenly. And over the course of this epidemic, 600 people would die. So Snow decided he would actually do a bit of an experiment and walk the streets, as any good epidemiologist would, try and gather the data. And here is his research output. And on this map, a line indicates a death. Okay, so and you can see that there seems to be a hot point of the epidemic around one particular well, which is the Broad Street pump. And then when you had a look at it, you had a look at deaths in the brewery. And in fact, no one died in the brewery because they all drank beer. And you had a look at the workhouse. And really there were only 5 deaths amongst the workhouse. And that was only people who had been recently admitted in the last few days. So if you looked at the deaths in the workhouse, which is in the same place so the miasma theory would be the same, you can see that the deaths in the workhouse were 1%, whereas the deaths in the local residents were some 19%. Just to add to the interest, there was a death from a lady in Islington, and she preferred the water from the Broad Street wells because it had more flavour, which is interesting in retrospect, isn't it? And she actually sent for that water every day. And similarly, there was a death from Hampstead, a lady visiting her aunt in Islington and drank the water. So, he went, argued the case, and published his results. And this is generally said to be a wonderful example of the public health model, where fine, excellent research, disseminated into the community, everyone fell on their sword and said, thank you very much, we'll take off the Broad Street pump, problem solved. The only problem is that that's actually not what really happened. So Snow's friend Edward Lancaster was actually at the famous meeting where he went and talked to the local politicians. Remember that the local government was seated in the local churches or parishes at the time. Snow went and demanded an audience. He said his bit, and in fact that they did allow him to take the pump handle off, but not because they believed him. It was more because by that stage some 600 people had died. They were really a bit of a loss to what to do. So it was, oh well, we may as well do that. It was more out of desperation than being convinced by Snow's argument. And in fact, it wasn't a month afterwards where the local populace demanded that the pump handle be put back. So people were far from convinced. I did a quote from the Sunday Mail before, which I must confess to making up, but I would not dare make up this review from the Lancet describing John Snow's work. John Snow claims to have discovered the law of propagation of cholera is drinking of sewage water. His theory, of course, displaces all other theories. Other theories attribute greater efficacy in the spread of cholera to bad drainage and atmospheric impurities. The fact is, the well which John Snow draws all sanitary truth is the sewer. His species or den is the drain. He is riding his hobby very hard and he has fallen down the gully hole and never since been able to get out again. Now, how is that from a letter to the editor in an academic journal? That's a bit scary, isn't it? So that is a literal quote out of the Lancet. And can you take away from that maybe people weren't very convinced by his ideas? Now, he was a local curate, if you like. He would be the community activist. And of course, he had 20% of his parishioners die within the course of a week. And this was more than a little crisis for this caring man, and so he was actually looking himself into that. He actually didn't believe John Snow's theory and did his own research, and he started off wanting to disprove Snow, but actually just ended up in the process discovering the index case, which then became convinced that Snow was right, and then they became collaborators. And in fact, a lot of the sharpness of Snow's final papers are owed to Whitehead, who actually described the index case. He was the one that figured out the story about the brewery, about the workhouse. He was the one that figured out the story about the lady from Islington that got it, because of course he knew all the practitioners. He had street knowledge, which really, really sharpened Snow's research. It's just interesting just to see his commentary about in retrospect, Dr. Snow's views on cholera are said by the medical friend of mine in 1855 to be generally regarded by the profession as very unsound. If that be the case, I replied, then heresy may be a good thing in your profession, as some are apt to suppose it is in mine. So they became collaborators. He actually found the index case, which was actually in a house right next to the Broad Street well. And what happened is the first child that got cholera, the mother came out and drained the nappies in the cesspool, which is right here, which was right next to the well. In fact, there was some crumpling of the bricks there, and so that the water from the cesspool was draining into the well, essentially. It took Whitehead, again, Whitehead did this, not Snow. It took him some year or so, or 2 years, I think it was, before that he actually convinced people to open up the well and have a look and see this drainage issue. So it took them a long time to produce this change. It's interesting to know what really changed it, because there was a lot of vested interest here, and of course from the gentleman's point of view they were wanting to reduce their taxes and maintain their prestige, and this was a problem that affected the poor people. And it wasn't until the Great Stink 2 years later in 1858 that the gentleman got motivated by this problem. And what had happened is that the Thames was overflowing with sewage. It was a very, very hot year, so all the bacteria overgrew and the Thames stunk to high hell. The other thing that had happened is that they had just finished their wonderful new House of Commons at Westminster, so the politicians moved into the London, into their wonderful new building, and found that it was so oppressive that they couldn't do the walk. You know, and everyone was talking about it. Michael Faraday, the famous physicist, wrote to the Thames saying, you know, this is disgusting. Can I say that the local people and the local people at the time put the link between the stink of the Thames, the shitty Thames, and the shitty Parliament. That was very much in the forefront of their mind even then, and I don't think that link should be escaped on us. Because actually, it had got to the point where they actually thought that Westminster was unusable, and it was this great stink that gave Benjamin Disraeli the leverage to persuade Parliament to spend some money to improve London's sewage system. So even this was the major change, even that change was driven by political self-interest, if you like, because poor people could die to the tune of 40,000 people, but as soon as Parliament got a bit stinky, suddenly they found the motivation to fix the problem up. Now, the other player in this is William Farr, who we might know as one of the first epidemiologists. He also believed in the miasma theory, and he actually published a study in the 1854 epidemic saying that the likelihood of you getting cholera was related to the height above the Thames. But it wasn't until the 1866 epidemic, some 8 years after Snow had died. And again, Whitehead was important in this because he was one of the ones, the bishop got Whitehead involved because, you know, people were dying again. Whitehead had that experience of the original epidemic, and it was Whitehead that talked to Farr, and that they made the link between the Old Ford Reservoir and that Farr became convinced that it was water contamination. So it wasn't until 10 years later that that link was made, and again, Whitehead was really crucial in that process. So, the reason I told that story to you is that big stinks are wicked. There's a will to act. The issue is very politicised, and the problem will be defined politically. The solution will be determined politically. Perception may be more important than fact, and there's a need to seen to act today, if not yesterday. And so there really is a high risk of jumping to premature conclusions, which might involve choosing the wrong problem or even choosing the wrong solution. So that is what happened with John Snow's story. And can I say that I think that analogy really does apply today as we work in the domain of public health. So big stinks are wicked. Chadwick in 1854 attempted to clean up the streets. And actually, like lots of wicked problems, you have a scientific intervention based on your current theory, and it actually makes things worse. Very characteristic of wicked problems. John Snow's there meticulously documenting that cholera is spread by waterborne contaminated water, but actually no one believes him. The big stint finally motivates Parliament to address the problem. So Benjamin Hall, arch rival of John Snow, might I say, and they had a very public confrontation over this issue. Eventually, after the big stint, employed Joseph Bell-Sketter as the chief engineer who designed the wonderful new sewer system. And it was really Whitehead and Farr in 1866 that managed to promulgate the link and convince everybody that it was contaminated water. Now, that's the cynical view, but nevertheless you would have to say that this is probably the most successful public health intervention of the time that's ever been. If you have a look at the number of deaths saved through those social reform interventions compared with our medical interventions, it is substantial. So this was a major breakthrough. So they were sort of at the time right for the wrong reasons. That they established the link between poverty and poor living conditions, and they had this unique idea that Chadwick promulgated that maybe the government had a role here, and by intervening to create a better physical environment that they could actually prevent disease. So that was a very novel, powerful idea that produced a major change, even though everybody at the time thought it was miasma rather than contaminated water. So just to bring this to closure, I would just like to put to the floor a vote of who do you think made the difference. Okay, so anyone going to vote for Chadwick? Oh, you don't like that cynical? No, you didn't like him then either. Anyone going to vote for Snow? Oh, one vote for Snow, it's interesting. Anyone going to vote for Henry Whitehead, the community activist? One vote for Whitehead. Anyone going to vote for Benjamin Hall, the politicians in their stinky Parliament House? Anyone made a change? Okay. What about the engineer? Anyone going to vote for him? And what about William Farr, the epidemiologist? There's not many people voting. Would anyone like to vote for everybody? Because I think that's really the take-home point of this story. And I probably, at that point, if you take that away, even in the John Snow, that there wasn't the researcher acting in isolation that was critical, it was a whole group of people that were involved in implementing that change. If you take that away from today's lecture, I have succeeded. Because when you look at the public health model, it's usually presented as like a waterfall where researchers define the problem, they do some epidemiological work to look at the risk factors and thereby identify causes, and then based on that they develop interventions, and then it gets to adoption and widespread use. And a bit like water travelling downhill, it's a relentless process that happens automatically, would be pretty much what is assumed by researchers working in public health, I would suggest. The problem is that that's not what happens at all. In fact, if this study looking at 1,200 health promotion articles, what they were about, most of them were essentially about defining the problem. A few were about identifying causes. Similarly, a few were about identifying interventions. And very few at all were actually about adoption and widespread use. And less than 1% were about implementation. So most of our research work is hugely dominated by defining the problems, primary epidemiological research, and somehow all these research efforts disappear when it actually comes to finally doing something about the problem. Now, it is said by researchers that this is a problem with translation. Here we may be in luck that translation is loose, but I think I overheard them say they've only captured us to save face. But it does seem like we have this research effort that basically after we test our interventions, we're travelling at a high speed and we hit a brick wall and actually nothing happens, and very few of our research efforts manage to penetrate that brick wall and get into the adoption and widespread use. Now, can I say, I think that's a huge issue, because unless our research is wonderful, and I'm not knocking the research, but unless it actually delivers population health outcomes, you have to ask, what's the point? And Einstein made this commentary, insanity is doing the same thing over and over again and expecting different results. So we keep doing this research-driven version of the public health model and it's not working and yet we keep doing it, well, maybe it's time to ask a question. So a number of people, Carolyn included, a lot of people at Monash actually are questioning, you know, is the public health model a myth? Does it even apply? Is this unhelpful? Just out of interest, it is actually worth going back to how the public health model was originally published, and it was published by Mercy in the domain of violence prevention, and he made a particular point of saying health brings a tradition of integrated leadership and all the scientific disciplines, organisations and communities need to work together. These problems are solvable, but we need to combine our diverse perspectives and resources to be successful. And in fact, his version of the original publication was a bottom-up model. So when Mercy published this, he was saying that researchers needed to work in collaboration with policymakers and the community to identify the problem, and that those people needed to be involved from the outset. So it's really interesting, where did we arrive at the point of this research-driven model that the researchers somehow do it for the community, because that's not what was ever said or intended with the public health model. So maybe it's not the public health model, but how we do it. Because in fact, Mercy was saying that everybody needed to be involved from the outset. So why is this the case? You need to mind the gap. And I put it to you that there are three gaps that are important. There is the efficacy to effectiveness gap, there's the research to practice gap, and there is the disease prevention to the health promotion gap. They're all about different ways people think about this problem. So let's talk about the efficacy to effectiveness gap, which is essentially, I would suggest, a scientific problem. I put to you that there is a problem with the nature of the science we're doing. That means that it can't be applied. It's not only that it's not applied, it's actually that some of our science is not applicable. So in the efficacy model, the efforts are focused on scientific content, particularly wanting to prove there is an effect, so they're wanting to prove internal validity, that the experimental results confirm the outcome. To do that, confusing factors like contextual factors or so-called confounding factors are excluded because they make it hard to demonstrate the relationship between A, the cause, and B, outcome, so it's specifically excluded. And in this way of thinking, impact is determined by, well, the number of people you reach with your intervention and how efficacious that intervention is. So it's nothing more than summing up the efficacious effect of all the people that are involved would produce the impact. And it assumes that success is actually a quality of intervention. So here's a study that the wonderful new Golf is the world car of the year. So success is part of buying the right car, if you like, the right intervention. But can I suggest to you that maybe that car might not be particularly relevant to my context? So if that's where I'm going to be driving, maybe that Golf isn't the most relevant car for me to purchase. So how can I know? Unless you tell me about where and how you did your research. So practitioners come from the perspective that context matters. Researchers attribute success to the intervention. Practitioners attribute success to managing context. And how do researchers deal with the confusion of context? They deal with it by reductionism, actually excluding it to try and isolate the effect between A and B. And in the physical sciences, it's been very powerful. But what about social determinants of health and safety, which have multiple causes? And is the sum component of a social system equal to the whole? We'll come on to that in network analysis a bit later. And could it be by focusing down on the detail, like focusing down on the microscope, that we're actually missing the main story here? And Rose made a commentary in this regard. We talked about it yesterday. He drew a distinction between sick individuals and sick populations, and making the point that those causes may not be necessarily the same, and you cannot assume that things that make individuals sick are necessarily the same things that make populations sick. called the ecological fallacy. And so doctors who are trained to treat patients are totally obsessed by individuals because they treat individual patients. And in that frame of reference, the doctors have been very heavily involved in injury prevention type research and public health research for that matter. They would say you have to identify the at-risk population, the high-risk population, and give your treatment to them. And that is true, that those patients are patients, even that's a statement, isn't it? They're not people, they're patients who are abnormal and need to be treated. You give them a treatment and make it better. Now that may be true, but the problem is that if you look at conditions, a lot of the incidence at a population level happens with so-called normal people. So it is true to say, for example, the person that is hypertensive, has a high cholesterol and is a diabetic, is in this group and they are at very high risk of having a heart attack. That is true. But in fact, most of the people that have a heart attack are in this so-called normal population. And so this idea that you can treat a population by treating abnormal individuals is untrue. And that's led to the idea that Rose proposed, that if a whole population is affected equally, we all play on the same football field, so if there is a problem with the grass on the football field and all the players are playing on the same football field, their risk is the same, so it makes it hard to measure epidemiologically that there is a difference. So you need to use different scientific tools to look at that, and maybe the better approach is to target at-risk populations. And that is the difference with effectiveness, where actually it's about the community context, and in this instance, research is very much focused on external validity, and context is the subject of investigation. And in that frame of reference, impact is determined by adoption, implementation, and maintenance. Now, can I put it to you that efficacy is not the same as effectiveness, and in fact, many of the strategies we use to prove efficacy are actually counterproductive or almost the opposite of the strategies you would use to show effectiveness. But can I suggest that both are true? That to have an impact, you need to have efficacious interventions effectively applied, which is the idea behind the REAIM framework, is to try and encourage people to report research in a way that's actually useful to practitioners. Now here's an implementation. A very clear message, but surprisingly, and it's very much an issue in Queensland when we've had flooding, that people are driving through all these signs and drowning in their cars. So as a research, we start with the scientific definition of need. We're very adverse to type 1 error. From our perspective, we actually want proof that an intervention works. On the other hand, we're very forgiving of type 2 error, that is evaluation failure to prove that it works. And from our frame of reference, success is determined by scientifically proved interventions designed by experts. But the practice community start with the community's perception of needs, and to deal with the problem they attempt to engage expert solutions and resources to solve the problem. And their objective from the practitioner's point of view, if you were Green's health promotion, would be to empower the community to solve its own problem. And in that frame of reference, success is determined by the ability to build consensus and the community's capacity to work together. So very different ways of thinking about the problem. Now, if that wasn't hard enough, let's throw in some politics. Ginger, why does the government have warnings on cigarette packages? Well, cigarettes are bad for your health. Why doesn't the government just ban cigarettes? Well, that would be bad for the government's health. So this gap, we really struggle, injury researchers struggle to deal with. And in disease prevention, we actually prefer the hard sciences of biochemistry and biomedicine. We're suspicious of the soft sciences like sociology and psychology. And health is hard to define, so we don't want to investigate it. We would rather investigate disease, because that's easy to define. And in this frame of reference, success is dependent on scientifically proven investigations. whereas in the health promotion, and can I say that that relentlessly comes across this block when it comes to the politics of trying to get the uptake. And that's because public health is messy. Really interesting papers about messy problems and wicked issues you should read. So, and they're parallel literatures, but for messy problems comes from Ackroft, and he was a business researcher. In a machine age, messy problematic solutions were approached analytically. They were broken down into simpler, discrete problems that were often believed to be capable of solving them independently. What we're learning is that such procedure not only fails to solve individual problems, but it often intensifies the mess, as in Chadwick's intervention to get rid of the smelly sewers in the streets of London. He just dumped it all into the Thames and made the whole situation worse. There's a parallel literature about wicked issues, and it's getting at the same issue. Because the problem is, what's the problem? And nobody's quite sure. And everyone has a different definition of what the problem is. And so that it's not until people can actually agree that you can actually do anything. And the characteristic of messy issues and wicked problems is implementing change. For every complex problem, there is a solution that is clear, simple, and wrong. In complexity science, it's called the butterfly effect. You do something, you think it's right, and it actually makes things worse. Now, can I give you a contemporary example of that? People quite rightly were concerned about head injuries from bike. Those that were in the injury prevention group, reporting from Monash the importance of bike injuries was there and how disabling they are. And so people had shown that helmets were very, very useful in protecting you from head injuries. So there was a big drive in Australia to have helmets. Now there's been questions raised because the population would choose to rather not ride than ride with a bike helmet. There's concern that in fact the loss of the bike riding has actually produced a paradoxical effect that has made mortality as a whole of population level higher. So this seems to be the characteristic of wicked issues. You do something that is evidence-based, you try it out in the real world environment, and then it falters and may even make things worse. So health promotion people think about it differently, that they would argue that behaviour is influenced by personal beliefs, attitudes, and context is important, and that you won't change the behaviour if the social, cultural and physical environment is not conducive to that change. And in that sense, success is about building wicked problems are solved by building consensus. So I've tried to show you those three gaps, and can I put to you that it's about context and it's about scientific complexity. The efficacy of effectiveness gap is really about the scientific complexity of generating knowledge in the real world. And in some ways we solve that by focusing down on the individual problems and exclude the real world. Of course that's a problem because then our research doesn't apply in the real world. The research to practice gap is about the complexity of applying knowledge in the real world. Because that's a whole thing again, even if you generate that knowledge, actually how you go about applying it's different again. And the injury prevention to safety promotion gap, the political problem, is about the social complexity of building consensus to actually intervene. So public health is complex. Let's think about that for a while. And as Carolyn said, one of the things I'm known for saying is that in injury prevention, behaviour is just like the tip of the iceberg. It's the obvious thing that you can see, but hidden below the waterline are interpersonal factors, the home, the peer group, family, organisational involvement, school, work, community type issues, and even issues affecting the wider society. And that these constrain that we are not free individuals at all, that we are actually constrained to behave in certain ways by our physical and our social context. And so that, yes, one sharp end of this model of causation is the individual, but so the physical environment's really important, and so too is the social environment. Not dissimilar to the idea of the 3 E's. education, environment, and enforcement. But I would put to you that education is a pretty blunt tool to change the behaviour of the individual, and I would also put to you that enforcement is a pretty blunt tool to address the problem of social perception. We'll come to that later. And complexity, it's really hard, but yes, it's very simple. At a micro level, if you try and break things down, because when you try and put all your individual causes that you demonstrate in an epidemiological study together, what you get is statistical chaos, that it makes no sense. So the relevance of so-called simple relationships between component parts at a micro level may be impossibly hard to compute at a macro level. On the other hand, if you stand back and look at the whole system, sometimes what is impossibly hard becomes very simple, because complex systems have this phenomenon called emergence, where very simple, almost irrational behaviours can be ascribed to complex systems. And in particular, one difference between reductionism and complexity science is this idea that the sigmoid curve. But there really is, rather than things changing in a linear way, there are tipping points, so that they have non-linear dynamics. So if you are doing an intervention and you measure it here, it might not have any effects. You might have to wait for another year or two before it reaches that point. So they have multiple feedback loops, all the variables are interrelated, they have non-linear dynamics, and at critical points, at tipping points, small changes in your control variable can produce large changes in the outcome. Context is incredibly important, and emergence is important. So you need to do a different type of science, and can I suggest you need to do wicked science. Now, here's a thing, and here is a description of a thing. How is it going to describe what this thing is and what it does? So it's broken it up. This is a reductionist type approach. Break the thing down into its component parts, study each of them individually, and that will describe what this thing is. Does it help scientifically? Can I suggest that the way these things are put together really, really matters from how a car works? And so the way, it's not only a quality of the attributes of each individual part, but it's actually how they are put together that is useful for describing how a thing works. Now that's called networks, okay? And in network studies, you actually not only study the people, but you study the links between things, how they're put together, if you like. And also you're very interested in structure. So we're just going to do a brief discussion of networks. Now we talked about public health, and you might have heard of the famous Framingham study. And this looked at the Framingham heart study, which is the study that showed if you had high blood pressure, if you had a family, if you're a smoker, if you had a family risk or a high cholesterol or a diabetic, you're more likely to have a heart attack. Now to follow up people, they actually collected data about who's your friend, who's your wife, who's your husband, who's your brother and sister, so that they could find them in 10 years. Remember, it's a cohort study that's been going on for 40 years, so they need to have some data so that they could find people. Now, Chryssakis actually used this data to construct the social network and do a network analysis. And he has done some very elegant work, basically a social network analysis. So he had a look at obesity networks. And what he showed there is that whether or not you gain weight was highly determined by whether your friend gained weight. So strong, in fact, that if your friend's friend's friend gained weight, it was measurable. And he didn't dare say it, the editors said it, that this social phenomenon is so strong it is more powerful than genetics. So this is a very hugely powerful force. So human beings do what their neighbours do.
This animation is a dynamic graphic representation of a portion of the Framingham Heart Study social network. Each circle or node represents one person in the data set. Nodes with orange borders are women, and nodes with blue borders are men. A white node indicates a non-smoker. The dark nodes represent smokers, and the darkness of each node is proportional to the number of cigarettes smoked per day. A line between two nodes represents a social connection between two people. Purple lines connecting nodes denote friendship ties. Green lines denote spousal relations. Other kinds of relationship ties, such as siblings, neighbors, or co-workers, are not indicated. This animation captures the years from 1971 to 2003, a period during which Americans quit smoking in large numbers, represented here by the number of gray dots declining over time. The animation also represents how smoking cessation may spread, given the influence that people appear to have on each other's behavior within a complex and evolving network of social relationships. During the 1990s, entire clusters of smokers within the network appear to quit in concert, and groups of adjoining nodes are seen to become white. Quantitative analyses demonstrate a tendency for smokers and non-smokers to form clusters within the network, and for smokers to move progressively to the periphery of the network, so that by the end of the study, the prevalence of smoking appears higher at the periphery of the network than at the center.
Smoking is a social phenomenon, and I think this study very elegantly demonstrates that. The reference is cut off at the bottom. His studies are reported in the New England Journal of Medicine. The obesity study has a video like that. Go and have a look at it, it's very compelling. Humans behave as part of a group, and if your friend stops smoking, you're more likely to stop smoking. And the effect is stronger the closer the relationship. And closer acquaintances are stronger effect than distant acquaintances. And interestingly, groups stopped smoking together, so it wasn't an individual choice, it was a group choice to stop smoking. Smoking is a social phenomenon. So I'm going to have a brief look at a network study I did at Mackay Safety Community. I just want to draw your attention to some characteristics of this social network because they are not unique to Mackay, they are typical. So firstly, I had a look at how this network changed in a period of 4 years and tried to put some numbers on it. Essentially, it got more cohesive. We had more relationships. People were better linked. Group action was stronger. And that was what we set out to do. And you could measure that by a thing called degree count, which is the number of people that are known. So the other thing that strikes you when you do a network analysis is some people are more equal than others. What about these people here? So if you had a look at just the number of relationships a person had, you can see this is a very, very skewed distribution, and a small number of people had a lot of relationships. They were really critical for how this system worked. It's called the STP phenomenon. Come across it, the same 10 people. It's also called the 80-20 rule. Okay, it's actually a pervasive thing you see when you look at networks. There's another type of relationship that's really important, and that is connecting relationships, because human beings are the conduit between information travelling from one group to the next. And that's really important idea I want you to latch onto. But again, that's even more skewed, and that a small number of people had 44% of all relationships and 60% of brokering relationships. So there's different types of change or social power that you can observe in social networks. One is bonding relationships, and the other is connecting relationships, bridging relationships, connecting people at about the same social standing. So this is relationships between Mackay Safe Community and other groups active in Mackay, and then linking relationships which go up the social hierarchy. And as you can see that we even tripled the linking relationships, and they were really important for actually attracting resources and expertise into Mackay Safe communities. So that it wasn't only the group power that was important, but these bridging or linking relationships are really important for the transmission of ideas. I want to have another look at another network, and this is a gay sexual network, and draw attention to the same, how would you stop transmission of HIV in this network? Well, one strategy would be to find the highly connected individuals, okay? But another strategy would be to find the linking individuals, because there's actually a very small number of individuals that link one social group to another social group. So they are really, really important for the transmission of disease. So if you can find those people, you can call this epidemic to a halt. The same idea applies, that those sorts of people are really, really important for the transmission of ideas. And in fact, in network analysis is very strongly linked to diffusion of innovation, that it would say that these highly linked early uptakers, opinion leaders are critical for changing the social values of a system. And innovation is very rarely new ideas per se, rather they are old ideas taken from one social group and put into another social group by these linking people who are really, really critical for driving innovation and transmitting change. So here is having a look. If you have lots of bonding social capital relationships inside the group, what you get even in science is groupthink. Everybody knows what everybody knows. Everyone's doing the same research, which is sort of relentlessly self-confirmatory, and so the outcome is very predictable. So that is actually not a very powerful place. On the other hand, if you have too many chiefs and not Indians, so they're all off on their wild ideas and they can't cooperate with anybody, that's not very powerful either. The powerful place socially is when you have these innovators who are strongly linked to a social group and transmit ideas back from one place to another. They are really critical for transmitting intervention. So can I just say an obvious take-home point to researchers and practitioners sitting in this room? As I have worked in Australia, I would suggest the link between researchers, practitioners, politicians and the community is incredibly weak, and probably getting weaker under the pressure of the dollar at the moment. So if you don't have a relationship, how can ideas be transmitted? Do you really expect that people are going to sort of just sit around all day and read obscure journals trying to find your work? You need to have those relationships, and if we want to drive innovation out of research into the policy making community and into the community and into the practice community, then we need to work extremely hard on developing those bridges, those relationships, and maybe you need to be thinking of becoming one of those bridges, or at least find one. So innovation is driven by transmitting one idea from the next, and so Einstein's comment on this is the secret of creativity is knowing how to hold your sources, because rarely ideas are new. So here is a model I have put in terms of how change happens, and basically bonding social capital drives the social norm, and bridging social capital and linking social capital drive change. So which type of social capital you want to work with depends on what you want to do. So if it's alcohol harm reduction, so the norm is drinking too much in Australia, then you're going to have to be working intensely, finding these highly linked people, these opinion leaders, and working with them to drive change. If smoking is the issue, where the prevailing view in Australia is smoking is counterproductive, you're actually going to be working with bonding social capital. So what type of social resources you use depends on what you want to do. I also think there is an issue of translation, but it's, dare I say, it's about communicating with the dark side. Being right is one thing, but what is the point unless you can engage others in the process of change? This is the hardest lesson I've learned as a researcher and practitioner in injury prevention. That it's not about being right, it's actually about building enough consensus to intervene. And Shaw made the greatest problem with communication is the illusion that it's a chord. Just because I'm publishing results, just because I'm talking with you today, doesn't necessarily imply that I am communicating effectively with you or changing your attitudes. So there's a difference between winning the argument and winning people over, and I think we as researchers need to think about that, because doctors tend to treat the community as if they're stupid. I'm smart, you're stupid, do what I say and everything will be all right. And can I suggest that the researchers tend to have that same degree of condensation sometimes to the practitioners. I'm smart, you're stupid, do what I say and everything will be okay. Part of the issue though is that the community is smart, it just measures things in a different way. So academics, administrators and politicians like cognitive messages. They need to be credible, They need to be based on sound science. Statistics and big numbers are impressive, and you need to prove that you're right. That is, disprove the null hypothesis, how it did. But in the general public, they think smartly in a different way because they know that there are any number of experts there. They know that there are politicians who are saying contradictory things. So how do they find their way through this quagmire of information? Firstly, they look at whether the source is trustworthy or not. So a politician's not considered very trustworthy in this kind of thing. They look at whether the person that's speaking is impartial and objective and not tainted by an agenda. And actually, absolute numbers are more understandable. Can I suggest to you that a lot of the things we use are very abstract? Okay? A million's a big number, but how big? What the hell is an age-standardised hospital separation? I mean, do you really understand what it is? Could you explain it to an ordinary person what that means? So it's a very abstract idea, whereas one person dying is much more concrete. And the community actually think about these problems. They want to avoid being wrong. So they're actually worried about type 2 error, not type 1 error. So can you see how we have a cross-conversation? And importantly, can you see how our scientific conversations, which are to aggressively argue the facts, are counterproductive? Because as soon as the community hears two experts saying different things, they say, well, nobody knows. And so it totally erodes any argument, any sense of coherence. So people decide to do nothing in that circumstance. Can I try and illustrate to this? We're trying to talk about the Cambodian fields. Here's two ways of describing that. So, go to which do you find more disturbing? On your left-hand side, all bones that you can count. Anyone want to hold their hand up for that? Okay. Who of you find one person about to die more disturbing? Even in an academic audience, the sensory immediacy of that person about to die has more traction. Okay? So here, if there's the paradox of risk communication, is big numbers actually have less impact because you can't count big numbers, they're abstract. So they don't connect to your sensory reality of the world. Small numbers have more sensory immediacy, you can count them, you intuitively know what they mean, and when confronted with big numbers, people actually disconnect from the personal cost of injury, so you don't have the effect. So scientifically now we're learning what the media have done is that the most powerful statistic is the statistic of 1. So if you want to make your message stick, you need to say it in a different way, and the reference is there. So success in communication has simple, unexpected, concrete, credible, emotional stories. You need to be a storyteller. And you'll see whether you think I succeeded or not, I tried to use that principle in telling the Jon Snow story. I tried to have an unexpected twist that was really reinforcing the point I was trying to make today. So to communicate well, you need to assume that the community is smart, you have to be trustworthy, you have to be understood, you have to connect, and actually you have to be involved in the debate, because unless you have a voice in the debate, you won't affect the outcome. So, how do you deal with wicked public health? Now, one approach is the ivory tower approach. This beautiful castle, it's internally consistent, it's lovely, it's got nice theory base, but somehow it's separated from the real world. I use to epitomise research somehow. Beautiful, but not really connected. Then you have the Coca-Cola approach, which is very connected socially, and dare I say we're being sponsored by Coca-Cola. But this is giving a very appealing sensory message, but in the end it's just water, sugar and carbon dioxide. So there's not a lot of substance to this. We need to have the best of both. And what I'd like to suggest to you is that injury prevention, while injury prevention is the science of controlling context, safety promotion is the art of managing context. Different approaches to the same problem, but both very important. And I think they need to be linked up. So who has the expertise and resources to fix wicked problems? Essentially everybody. The problems are too complex for any one person to get to grips to. And can I say that in essence, wicked issues are problems of cooperation. Once you get your brain around that, then you know what you have to do. And yes, we need to do our basic science, but we also need to do our social science to understand what socially do we have to do to make people cooperate. So, we're in Sydney. If you're going to build a bridge like the Sydney Harbour Bridge, I suggest you need you need to think about three different types of people. You need to think about the designers, you need to think about the workmen who are the builders, the engineers who put it all together, but you also need to take need of the cognizance of the need of the end user, because there's no point building a bridge if everyone wants to just take the ferry anyway. So you need to think about all those types of people if you're going to build an effective bridge. So in keeping with that, I think there are three different types of experts that are required to define wicked public health interventions. Yes, of course you need the researchers, the context experts, who know why and what to do. They understand the best methods or the best evidence. But you also need the process experts, the practitioners and the policymakers, who actually know how to do it. They understand best practice. You need to research that as well. And we all too quickly forget the context experts, the target community, that they understand themselves and their own needs and their own barriers. If you're going to decide an effective intervention, you need all those people. But it's not interdisciplinary, because that's a smaller place where all those three people can agree necessarily. It's not even multidisciplinary, just adding everything up. Can I actually suggest it is about transdisciplinary intervention where everybody is involved in the conversation and everybody is changing their thinking based on the conversation. And we really, when we did this, we had lots of discussions about this with Carolyn, we really liked the idea of this sort of continuous integration, a conversation that is ongoing, and as that conversation happens, the things get sharpened along the way. So the wicked public health model isn't linear, and it isn't just about researchers propagating their ideas to practitioners and the community. Everybody needs to be involved. But the problem about wicked issues is that it's hard to know what the problem is. You have to get agreement, and the trick to it is to start. You start with your best guess, and you apply your best guess, and you see what happens, and then you have a process of continuous cycle of quality improvement. And that is, I think, the big difference with the public health model I would like to suggest to you. Everybody needs to be involved from the outset. Yes, researchers are involved in the conversation, practitioners and the community. They have a look at what they think is the most likely source of the problem, and then you start to apply it. Now, anything that is difficult, who could imagine an Olympian just reading a textbook on pole vaulting and then going out and jumping over and winning the Olympics? It just doesn't happen, does it? It happens through practice, tuition, experts, coaches, other peers. As they work through that process, they practice and practice. That's too high, that's too low, I need to do this to jump higher. It's a process of continuous quality improvement. Why should we think public health, which is so difficult, would be any different? This is a process of continuous quality improvement that's involved, that is achieved by a conversation between researchers, practitioners, policymakers and the target community. So what has to change? Yes, it is about translation. The message needs to change. We as messengers need to be sharper as translators. Of course, we want the recipients to change as well. But how can we expect others to change if we're not prepared to change ourselves? How condescending. I actually think everybody needs to change. The message, the messenger, and the recipient, and we need to have transdisciplinary research that is producing transformation, fundamental change of all those things. So in summary, I reckon the science push version of the public health model was a myth. It was never true. It wasn't what was proposed. In its current form, injury prevention research is incomplete because unless it's implemented it won't save lives. It's insufficient. We don't report what the practitioner community needs to know to see whether their application will apply in their context. We need to talk about the re-aim stuff. But it may even, some of our research may even be inapplicable. It's not applied because it can't be applied in a real world setting. Public health is wicked. So we need to communicate differently. We need to communicate successfully. We need to think about who our target audience is and pitch our messages to them. So if we're talking to the community, our message is going to be different than if we talk to policymakers and if we talk to researchers, or we need to have an appropriate message. And we need to be transdisciplinary, and I think in the end that this is fundamentally a transformative process in which everyone changes the process to a conversation that is iterative and gets sharper and sharper as how things go on. That is how real problems are solved. Thank you. Secretary.